Mazin, is there a way to know if people can answer this, or shall I just keep going?
There is few answers starting to come down. So
Okay.
I have transferred to tertiary cardiac center. I have called cardiologist and sent EKG, and I have administered aspirin, clopidogrel, and enoxaparin.
Okay. Okay. Do you want us to go on, or?
Yes, I believe so.
Okay. All right. Okay. So this is good because we'll discuss we'll go through the presentation, then we'll go back to this question and see if people want to change their answers. So acute coronary syndrome is defined as acute myocardial ischemia caused by coronary plaque rupture with superimposed intracoronary thrombus and associated with increased risk of sudden death. Okay, so I can see, I kind of saw a snapshot. Okay, so the key things to understand that obviously this is somebody who has a ruptured plaque and then developed thrombosis on top. So if we look through this diagram, you can see that people who have acute coronary syndrome are demarcated by 5. This is where there's a normal vessel is 1, 2, and 3 is where most people are, where they start developing plaque rupture, develop risk of coronary artery disease. And here are patients who have borderline lesions on angiography. These are the ones who are likely to get a ruptured plaque. Once the plaque ruptures, it triggers the coagulation cascade, and then you develop an acute coronary syndrome. Okay. So the acute coronary syndrome can be of 2 types. Either there is complete occlusion of the vessel, and that is what's called an ST elevation myocardial infarction, because the occlusion of the vessel is seen as ST elevation on the EKG. Then you have the other group of patients who have partial occlusion of the vessel, and these patients do not have ST elevation on the EKG. So the differentiation of complete occlusion or partial occlusion is defined by the presence or absence of ST elevation. So if you have ST elevation, you have an ST elevation MI. If you do not have ST elevation, you have non-ST elevation acute coronary syndrome. But like most things in medicine, nothing is perfect. A few minority of patients who have complete occlusion of the vessel may not have ST elevation on the EKG. And that's usually what happens in the left circumflex territory, which can be silent by EKG. And some patients who have non-ST elevation MI initially may progress to full-blown ST elevation MI. So these 2 slides actually show you what the focus of treatment is. If you have ST elevation MI, your goal is to open the vessel. And that is what's called reperfusion. In patients who do not have 100% occlusion of the vessel, then your objective is to prevent them from becoming ST elevation MI. So that's why you focus on risk assessment to determine which patients need to go for higher levels of care. Once ST elevation, if it's untreated, will progress to form Q waves on the EKG. So the presence of Q wave in the EKG is a late finding in patients who come with ST elevation MI. The old name for it was Q wave MI. The current name, which has been there for probably more than 20 years, is ST elevation MI. So then the question then comes to the importance of timely intervention in patients who come with ST elevation MI. And that is where the principle of time is myocardium came up. This is something which is not new. It's been around since 1994, as you can see. So this is what's called the FTT collaborative group. They lumped patients from different thrombolysis trials. They had more than 50,000 patients. What they found was, as time goes by, you lose benefit from thrombolysis. So the most benefit you get is in the first few hours from onset of symptoms. So if you come very early, thrombolysis will save more lives. As time goes by, you start losing benefit from thrombolysis, and then until at a certain point, there will be no benefit from thrombolysis. So if you go back to the patient that we saw, he came with 1 hour history of chest pain. He's somewhere here, right? So when he is there, the more you delay in giving him thrombolytic agent, the less benefit you get from that medication. And this is maybe an easier graph to use. So as you can see, if we go back to our same patient, this is where you want to intervene, because this is where you get the most reduction. So your objective as a treating physician is to try and save lives. I mean, that's essentially save lives and improve symptoms. Saving lives is central to why we have emergency rooms in the first place. So this is where you really want to get your patients. That's where you really want to intervene to save lives. This is the golden period where you get maximum benefit from reperfusion. So in our patient who came at 1 hour, time is not on your side. You need to intervene, and you need to intervene quickly. And the faster you get it done, the more the benefit. Once you start intervening late, then that is when you start losing the benefit. And once you go into 6 hours and 8 hours, then everything else you do does not have a big benefit. Okay? So based on that, let's go back to the question and see if people want to answer again. So again, 52-year-old male who came in with no significant past medical history to the emergency room in Sudan, and you have streptokinase, and you have this EKG. What would you like to do next?
Our attendees, you will be able to see the poll in front of you, so you can just select the answer that you believe is most appropriate. So far, Dr. Salah, 50% are going for streptokinase.
Okay, very good.
33% for tertiary cardiac center referral.
Okay, very good. So at least we made a change. So that's a good thing. Now, the reason I asked this, the reason I put this question is because I worked in Sudan for 18 months and I know exactly what people do. This ECG shows anteroseptal ST elevation MI. And I chose something which is extremely clear so that you shouldn't have a diagnostic challenge in making this diagnosis, right? Obviously, not all the EKGs like that. And, there is a significant number are actually gray. You can't be sure. And it's fair for you to send it to someone to double check, and you definitely should do that. But I chose this EKG is because it's very obvious. Any delay you do, if you want to administer aspirin, clopidogrel, and enoxaparin when you're practicing in Sudan, is going to introduce delays. Finding the pill, asking the patient to go and get it from the pharmacy, prescribing it, that's going to delay you. Checking labs is going to delay you. And as we saw in these graphs, time is myocardium, every second counts. So this really what I would try to get you from this presentation to do is to change, if your reflex is to do lab testing or administer medications which are not thrombolytic agents in people who have a STEMI, then I think we need to do a paradigm shift. We need to think about lytics first and then do the rest later. So as you don't delay that patient. And I think if you do that, you will save more lives. And the other thing to note is this patient came 1 hour only. Now, obviously, if the patient came 6 hours or 8 hours, then you already kind of missed the benefit. And that's what's called the total ischemic time. The total ischemic time is the parameters that determines outcomes. So if the patient comes 8 hours late, there's nothing much you can do. And that applies to any therapy you use. But if the patient came early, then it's on the hospital and it's on the system and it's on the physician to make sure they get timely reperfusion. So that's the first point from the presentation. We can go to the definition. Now, the ECG definition is something that somewhat evolves. I think recognition of a STEMI on EKG is a skill that that is developed by pattern recognition. And as you get more experienced, you get better at it. And you'll be able to be more both sensitive and specific in diagnosing ST elevation MI. This presentation, we're not going to go into the depth of ECG interpretation. This is something that can be discussed at a later time. So ST elevation is defined at the J point. It's defined by having the elevation in two contiguous leads. The definition of contiguous means that two leads that are in the same area. So you have V2 and V3, or V3 and V4, V5 and V6, V6 and AVL, AVL and 1. So these are defined as contiguous. So if you have AVL and AVF, these are not contiguous. And obviously 2, 3 AVF are contiguous leads. So that's the definition of contiguous. The cutoff points generally is 1 millimeter. 1 millimeter is one small box. In all leads except V2 and V3. For the others, you want bigger ST elevation. You expect to see bigger ST elevation in younger males as opposed to women, for example. Now, obviously, because of the very big emphasis on timely reperfusion, there are certain guidelines that came up to guide triage in the emergency room. This may not be as applicable to Sudan because not all places will have triage, but if you had a system by which you wanted to make sure that you detect STEMIs very early on, then there are certain triggers that the triage nurse would have that would tell her to do an EKG. So any patient above 30 who says they have chest pain would immediately trigger performance of an EKG before evaluation by the physician. In patients above the age of 50, any shortness of breath or altered mental status or upper extremity pain or syncope or weakness would trigger ECG performance. And if in the very old, you add other symptoms like abdominal pain, nausea, and vomiting. The whole idea behind that is to make sure that you do ECGs in all patients who potentially have STEMI, including those who come with atypical presentations. This has been studied in an article that was published in 2012. Now, as far as fibrinolysis, the commonest agent available worldwide is streptokinase. It's an old medication. It's been around for a very long time. It's given as a 60-minute infusion. The dose is 1.5 million units, and it is associated with significant reduction in mortality in patients who have ST elevation MI. It has low bleeding rates and less strokes when you compare it to newer agents. And as I said, it's the most widely used agent worldwide. It's highly antigenic, so you should not give it more than once. Obviously, sometimes you have to when you don't have other options, but you do, if you give it a second time, you risk development of severe allergic reactions. And that is something you should avoid. Now, the other agent, which is also very limited availability in Sudan, but it is there, Altiplase or TPA, is given as a 100 milligram infusion over 90 minutes. Half the dose is given within the first 30 minutes, so it's called an accelerated infusion. In the Gusto trial, it has been found to be superior to streptokinase. It's fibrin specific, so you don't form antibodies, so you can give it more than once. It is associated with more bleeding. Then there are two agents which are available, which is not, I don't think they're available in Sudan, but they are, it is the agent used, for example, in India, they use Tenecteplase. This is the advantage of that, is that it's given as an IV bolus, you don't need an infusion. That's why it makes it fairly easier to use in an ambulance setting. It is comparable to Altiplase in efficacy in two trials, which were the Gusto 3 and the Ascent trial. So this is a slide that kind of summarizes the medications that you administer in somebody who comes with ST elevation MI when you are using fibrinolytics. So the first thing, obviously, is to get an EKG or an ECG and administer fibrinolysis. Okay, and even you can see that if you look at it very carefully, they also agree that the fibrinolysis should always be given first. Anticoagulation is generally recommended, and there is specific dosage that you can find in detail in the guideline. You load aspirin, you load clopidogrel. Once you've given thrombolytic agent, once you've administered streptokinase, then you can take a deep breath, and then you can start thinking about what to do with the patient. So in case if you're working anywhere in Sudan, so the first thing you do, ST elevation MI, do an EKG, administer a thrombolytic agent, and then after that, think about what to do with the patient, okay? Don't think about what to do with the patient before you give thrombolytic agent, because then you lose the benefit. But if you administer thrombolytic agent, at that point, then transfer the patient. But please give the thrombolytic agent first. Once you give it, then do the transfer. And then you can write a prescription for aspirin, write a prescription for clopidogrel, write the prescription of enoxaparin, think about dose of enoxaparin, whether how much you're going to give it. So all of these things can be done. But first, give the thrombolytic agent. Okay. What happens after that is actually, you should, if you can't transfer them to a tertiary center, then admit them, then find a place for them where they can be safely monitored. And that would generally be an ICU setting. Okay. Okay, any questions so far before we go to the next problem?
No questions so far, Dr. Salah.
Okay. All right, so then we go to the next problem. We have a 76-year-old female who comes with 2 hours history of chest pain. She said she had brain surgery 2 weeks ago, and she has a visible scar on her template. So what are you going to do? Can you show the poll, Mazin? Okay, so it's the same things almost. I think I took off one choice. So check labs, transfer to tertiary, call cardiologist, or administer septokinase. So now I changed the theme. So now the ECG changes are in a different location, and there is something else with this patient which makes it a bit different.
Polls are coming in, and I see 100% so far opting for transfer to tertiary center.
Okay, very good. So that, I think this is not surprising. So generally, I think one of the scariest decisions, I practiced for a short period of time in the United Kingdom, and I kind of understand the reluctance to give thrombolytic agents, because what you fear is intracranial hemorrhage, right? And I think that's why, and definitely safety is first, but in thrombolysis, I think we should be both safe and also we should try and save lives as much as we can. So the main thing you're worried about is really this, right? The worst thing that can happen if you give thrombolytic agent to a patient who does not need it is to put them in harm's way. And that is by causing intracranial hemorrhage. So the example in this case, this is somebody who probably had brain surgery. So generally you should not give them that, because this is what's going to happen. And once this happens, then the patient will probably die, right? And I think that's why, that would explain why people don't give it, because they're worried about causing harm. So that's why you should definitely give it in the right patient. And that is where it becomes important to improve your ECG skills, and also to know about which patients are more likely to be harmed. So thrombolysis generally, the very old, the small weight, and uncontrolled hypertension are the most at risk, okay, of getting intracranial hemorrhage. And that is a disastrous complication when it happens. So this is a table from the guidelines. So there are certain absolute and relative contraindications for giving thrombolytic agents. Anybody who's had previous intracranial hemorrhage or stroke of unknown origin of any time is an absolute contraindication. Ischemic stroke in the preceding 6 months, CNS damage or neoplasms or AV malformations, recent major surgery, GI bleeding within the last month, known bleeding disorder, menstrual period does not apply, aortic dissection, or you had a non-compressible puncture in the last 24 hours. So these are all contraindications to administering thrombolytic agents, and these are absolute contraindications. Relative contraindications include things like TIA in the last 6 months, oral anticoagulant therapy, pregnancy or within 1 week of postpartum, refractory hypotension, advanced liver disease, infective endocarditis, active peptic ulcer, prolonged or traumatic resuscitation. From a practical standpoint, one thing you can do, which is very easy, is just take a picture and put it in your phone. And because once you have an ST elevation MI, you'll get the adrenaline surge and you may not remember all these things. So that's why this is where things like checklists help a lot. Or just take a picture, put it in your phone. Next time you see a patient, just go through it. And that will make life very easy for you. If the patient has a relative contraindication to thrombolysis, that would be a good point for you to discuss with someone else so that they can share in the decision with you. So it's not only your decision. But if you have a patient who comes with an ST elevation MI on the EKG, and you went through all the contraindications and you did not find any, then by all means give it. Okay? By all means give it and don't delay care. Okay. Then we go to the next problem. So here we have another EKG. We have a 65-year-old female with past history of diabetes and hypertension who presents with 20 minutes of chest pain while watching TV. So we have the EKG here, and I can help you out and tell you that this does not show ST elevation MI. We've moved on from ST elevation MI, and now we're going to talk about non-ST elevation acute coronary syndromes. The troponin is increased, so you diagnose it as a non-ST elevation MI, and you start on medical therapy. So what do you want to do next? And this, I think this one is actually, it's not the best of 5. It's more or what is the best approach. So you can answer more than one. I don't know if the poll lets you do that or not, but you can select more than one answer.
Okay, more and more votes are coming in. So far, the majority are voting for consulting cardiology for cardiac catheterization plus minus PCI. And ordering echo is the second runner-up with 33%. And there is 1 vote each for TPA and EKG stress test.
Okay, all right, that's informative. So I think as far as, so we'll go through the presentation, then we'll come back to that one. So now we're talking about the patient who came with chest pain and did not have ST elevation on the EKG, okay? So this is something which you have more time to think, and you have more time to do things. So as far as we said earlier, when non-ST elevation acute coronary syndrome is actually when you do not have 100% occlusion of the vessel. So the vessel is still patent, okay? So the vessel is open. So then there are measures you can take to determine the risk of them going into an ST elevation MI or dying as a result of the non-ST elevation acute coronary syndrome. So there are things in the history that you can find. There are things in the examination, and there are findings on tests that tell you about the risk of the patient. And what you're going to do there, the risk will determine your next step. So there are patients who are going to be high risk, and there are patients who can be low risk. So the higher the risk, the more inclined you are to take invasive treatments. Okay, so high-risk patients will go on to have cardiac catheterization with an intent to do PCI or surgery, depending on their anatomy. While those patients who are low risk are those who you can treat with medication without having to think about sending them for PCI. And this matters for 2 reasons. Yeah, there's the general emphasis, obviously, is that there are low-risk patients, especially females, who may be harmed by cardiac catheterization. In Sudan, it's more important also because of cost. Going to send a patient for PCI involves a huge amount of sum of money that is not available to most people. So you want to justify that expense. So if you have somebody who's low risk and cost is a major issue, then maybe you can just avoid sending them to cardiac catheterization and PCI safely. And this way you save money for the patient, right? So, and that's why it's important. So in the history, prolonged chest pain, which is ongoing, is higher risk than people who have a single episode of chest pain. Somebody whose symptoms are accelerating are at more risk than people who have single episodes. Risk factors are age, prior MI, and atherosclerotic risk factors all increase your risk if you have them. So if you have somebody who's 42 years old, young, is probably lower risk than somebody who's in their 70s who had a previous MI and who has diabetes and hypertension, etc. Prior aspirin use, because aspirin should protect you from getting these acute coronary syndromes. So if you're already on aspirin, you're probably at higher risk of complications of non-ST elevation acute coronary syndrome. Things to look for in the examination: patients who have hypotensive and tachycardic or hypoxemic and congestive heart failure are more high risk than those who don't have that. Signs of heart failure like raised JVP, a third heart sound, chest crackles, and lower extremity edema, new mitral regurgitation, all these things make you at higher risk. And these are things which are usually obvious from your initial assessment. Now, as far as testing, most patients who come with non-ST elevation acute coronary syndrome probably don't have a lot of findings on examination. That's where you go back to the EKG. If you have ST depression, so if we go back to our patient, so actually I'm not sure how well you see it, but there is some ST depression which is kind of diffuse. You can see it in V2 to V6. You can see a little bit of it in AVL and V1. And he also has ST elevation in AVR, which is indicative of fairly high risk non-ST elevation MI. T-wave changes like depression and biphasic T-wave changes. Obviously, any arrhythmias increase your risk of complications, and elevated cardiac biomarkers. So all of these things go into your risk assessment of someone who comes with a non-ST elevation acute coronary syndrome. And there are different risk scores, which you can actually, if you have, you can just, there are some calculators you can find online and they're free, where you can put in all the risk factors you know, or that you manage to identify from your assessment, history, physical examination, investigations, and then these will tell you what's the patient's risk. And this can give you a number, and then, you know, if you like to do risk scores, then this is something that can help guide your therapy. So that's as far as risk assessment. So risk assessment is an integral part of non-ST elevation acute coronary syndrome management. Patients who are low risk are those who you can treat medically, while those who are high risk are those who you refer to a tertiary center. Okay. Do we have questions here, or shall we go to the next problem? Or actually, let's go back to answer our question. So if you look at our patient here, so she has diabetes and hypertension. So first thing is we establish a diagnosis, right? We establish a diagnosis of non-ST elevation acute coronary syndrome, and now we want to risk stratify. So if we go to the history, she has diabetes and hypertension, so that puts her at a higher risk. Her episode of chest pain was at rest, so that puts her at a higher risk compared to somebody who has more exertional symptoms, and troponin is an increase, and she has ECG changes. So based on that, without even going into calculators, you can easily see that this is a high-risk patient, right? So if it's a high-risk patient, then I'm going to think of invasive therapy. High-risk patient, I'm going to think of invasive therapy. So this is the kind of patient, if he asks you if that is worth raising funds for to get a PCI. Within the things you do, that is somebody who will benefit from having PCI or surgery, right? Because their risk of dying is fairly high. If the same patient came with symptoms, but no ECG changes and negative troponin, then these patients are low risk. These patients are low risk. These patients, you can put them through a stress test. If their stress test is negative, then the risk is even lower. You can manage them medically, and they will have a low, their risk of complications is low. And that's where the assessment comes. Okay? So any questions about risk stratification before we go to the medications?
I don't see anything so far, Dr. Salah. I think we can proceed, and we will keep an eye out for questions.
All right. So then we go to the next question. So this is the patient. She came to the emergency room. She came with chest pain, and her ECG showed sinus rhythm with no ST changes. Her troponin was increased. She preferred a non-invasive approach. So that one of the other things which to add that, you know, if patient doesn't want to go through procedures, then a non-invasive approach might be reasonable. So an echocardiogram was done. It showed normal LV systolic function. You put her on a treadmill. She was negative for ischemia. Her LDL is 150. And now she's chest pain free. She's fine. You did the risk stratification. You wanted to do CAD, but you wanted a non-invasive approach, and then you did the stress test, and it came back okay. What are you going? And now she's ready to go home. So what are you going to discharge her on?
Okay. So the poll is up, and please note that you can select more than one option at the same time.
Okay, are we getting any answers?
92% of the participants selected aspirin once daily for life. Between statins, 54% said atorvastatin versus 38%, and clopidogrel is equally divided between for life versus 1 year.
Okay, very good. So this is something else which I found from practice in Sudan, and I think that's important. So let's address it. So I think first thing, aspirin, all patients, 100%, this is correct. You all know that. Now, generally speaking, in patients who come with acute coronary syndrome, clopidogrel should be given for only 1 year. Okay, it's 1 year, right? And that came from the CURE trial for the non-ST elevation acute coronary syndrome. And most of the studies, they stopped at 1 year. So whether you do a stent or not a stent, whether you medically treat, whether you put a stent, or whether the patient even came late with an ST elevation MI beyond the treatment window for thrombolysis, or even if they underwent cardiac bypass surgery, the duration is 1 year. The duration is 1 year. Okay, and this is fairly common in Sudan that once patient has CAD, aspirin and Plavix is on board and nobody stops it. Everybody continues keeping it. Okay, and that does not have benefit. It has never been proven that giving dual antiplatelet therapy indefinitely is of value. And in Sudan, it's a problem because it increases cost. You're increasing the cost of care. If you count all the, and you know, money is limited. So you really, if there's ways to cut costs, then please do it. So that's another thing. Now, as far as statins, I gave you an LDL of 150. You want to zap it down to 70 or less. You're not going to get there without a high dose of atorvastatin, right? So give high intensity statins. So the high intensity statins are either atorvastatin or rosuvastatin. These are the two agents which really bring down your LDL. And that's important because these patients, you want to reduce their future events. And this is a high benefit intervention. So within all the medications we prescribe, high potency statins work. They save lives. So give them a real dose, right? Especially because I don't think the cost increases if you go by the dose. I know that atorvastatin, for some reason, in Sudan, they don't have the 80 milligrams. So you have to give 40 milligram 2 tablets, I think, and that increases the cost. But this is something worthwhile doing. Okay, give high doses of statins, bring down the LDL. Okay, especially when the LDL is as high as 150 in that example. Okay. That's to summarize: aspirin for all patients, clopidogrel for 1 year, regardless of whether you do pre-perfusion or you don't do it, and high intensity statins. Tamam. So yeah, and so that was the last slide, and there's a couple of resources for you to look up. You can, for the STEMI guidelines, European guidelines are very easily written. They're very easy to read. So you can actually just look at the pictures really, and that will give you a lot of the information you need. If you want to look more about the slides and where I got the information from, then you can look up these articles, which also have some additional information.
اوكي طيب لحد الان ما عندنا اسئله سواء في الفيسبوك او على اجتماعنا هنا في زوم. فدكتور صلاح عايزين منك تدينا زي closing remarks لو في حاجه معينه حابب تنوه عليها او تشدد عليها.
فأهم حاجات طبعا okay, so there's a few things. First thing is you start from the beginning. Acute coronary syndromes are all about how you respond to them. So if patient comes with chest pain, do an EKG early. Once you see the EKG and you diagnose an ST elevation MI, then time is myocardium. Assess the patient for thrombolysis. That assessment should include ruling out contraindications to giving it and the duration of symptoms. So if patients came outside the treatment window, don't give it. If the patient has contraindications to thrombolysis, don't give it. If you're not sure about the EKG, ask someone, double check it with someone else. But if the EKG is obvious and the patient came in the treatment window and does not have any contraindications to thrombolysis, don't waste time. Okay, just give it. So that's the first point. Once you gave it, after that, then you can start doing the medical management, give aspirin, give clopidogrel, give enoxaparin or Clexane, as it's called in Sudan, and transfer the patient to a tertiary center and put him in a monitored bed. So that summarizes the whole STEMI portion. For patients who have non-ST elevation acute coronary syndrome, make sure they're on good medical treatment. Make sure they're on aspirin. For Sudan, make sure they're on clopidogrel. And make sure they're on a high-dose statin. If they have high troponin and ECG changes, and you can, send them for an invasive strategy. If they have low-risk features, then you can discharge them to do a stress test. And you can do that safely. But if they have high troponin, then you probably don't want to do that. And these are the kind of patients where it's reasonable and probably beneficial to have a conversation with your cardiologist early on. Okay.
دي حته مهمه دكتور صلاح لانه في سؤال جانا بخصوص الستريس اي كي جي انه في الكونسيرن طبعا انه ما يسترس someone who's going through an acute event. So I think a risk stratification is very important.
Yeah. So the best and simplest risk stratification is a troponin. You have somebody who comes with symptoms suggestive of CAD and the ECG shows no changes and their serial troponin is negative. So that is usually the 12-hour troponin is negative. These are low-risk patients. Okay? These are low-risk patients. So these you can put on a treadmill. If the troponin is positive, don't put them on a treadmill unless a cardiologist tells you to. And in that case, you know, maybe he should do it, right? So, yeah, so that I think that's, there's other things you can do like echocardiography, which as we showed in that example, if you have normal LV function, then that adds to your safety. But even that with a positive troponin makes it unsafe.
في سؤال ثاني دكتور صلاح بخصوص الثرومبوليتيك انه do we need to wait for CBC and bleeding profile result before lysing the patient?
Yeah, no, that's a whole, yeah, that's a good question because that was part of the questions we addressed. Unless there's a strong reason to do it, don't do it. So what is a strong reason? Strong reason is if somebody's clearly cirrhotic, right? Somebody clearly has liver cirrhosis. Then you know it's likely their platelet count is going to be low. It's likely their INR is going to be high. You want to know in that case, right? That's one example. The other example is somebody who he's on warfarin. You want to know their INR, right? Because it becomes a relative contraindication if their INR is high. But if you have somebody who has no past medical history, زول قال لك زول نصيحة يعني جاي ما عنده شيء، عمره 42 سنة شاب، ما شاب لكن مهم، جاك بchest pain وعنده ST elevation MI كبيرة في الECG. What do you think the CBC and INR will show? Right? So you have to employ your clinical judgment, you know? You have to do that. And you know, you don't need it. That's I guess that answers the question. No, you don't need it in patients who don't need it.
Okay, and Dr. Salah, there is another question about late presentations. I assume it's STEMIs. So the question is, what if a patient presents later than 72 hours from the onset? Any benefits from coronary angiogram?
Yeah, I mean that's so yeah. So I think so that's another common scenario that patients come late, right? So if the patient comes late, and we saw that in terms of the graph. So the first thing is they're outside the window for reperfusion. Once you're outside the window for reperfusion, then the other things بتبقى يعني تبقى تحصيل حاصل يعني انت the things تبقى بعدك السؤال what can you do to change things, right? You can't change much in terms of the MI. You cannot change after 72 hours of an MI. You can't change what happened. But what you're going to do is going to try to improve the future. So your focus as a non-cardiologist is medical therapy. So you put aspirin, you give clopidogrel for 1 year, high dose statin, and for STEMI is beta blocker and ACE inhibitor. And if they have low EF and diabetic spironolactone. So that should be the focus of what you do. And you should send them to a cardiologist. As far as from a technical standpoint, you have somebody who came with an LAD occlusion and his 72 hours out and you put a stent, it doesn't work. It's called the OAT trial, right? It doesn't work, so don't do it. Obviously, okay. if you find lesions in the other arteries, then that might be a different story.
We have few more questions coming. First question is, in patients with end-stage renal disease, with troponin elevation, what is the threshold that will get you worried about, a genuine acute coronary syndrome versus a small troponin leak just from having ESRD?
Yeah, so that one goes to so patients like that. So these are worth getting a cardiology consultation because these can be difficult to decipher. So if you have end-stage renal disease, you can get increased troponin due to demand ischemia. So that goes to clinical assessment. So you have to assess, do they have chest pain or not? Do they have ECG changes or not? How high is the troponin? Do they have new changes on echo? In many cases, you may end up not being sure even unless you do a stress test. And so these are things which need to be individualized in terms of how you approach them.
Okay, another question is about patient with right bundle branch block who present with chest pain. How are they treated, or are they defined as, I assume it's MINOCA, and MINOCA for those who are not familiar with the term is myocardial infarction in the absence of obstructive coronary artery disease.
Yeah. So what was the question?
The question is people who come with chest pain and right bundle branch block.
Yeah.
So like they have an underlying bundle.
Yeah, so as far as EKG interpretation, generally speaking, right bundle does not usually interfere with STEMI detection, unlike left bundle branch block. New right bundle branch block may be associated with worse prognosis overall. So it does not interfere with the STEMI diagnosis. You should be able to diagnose STEMI with right bundle branch block. If you have left bundle branch block, it becomes more challenging. And I think such an ECG, it's reasonable to share it with a cardiologist before you make a thrombolysis decision, okay? And that's important. So, so that's one thing. MI with normal coronary arteries is a post-cath diagnosis. So usually you have to do some form of angiography, usually invasive angiography, to make that diagnosis. So, and it suggested more of microvascular ischemia and, things like that.
Okay. Our next question, Dr. Salah, is about statins. So the question is, in Sudan, we are prescribing statins almost in all acute coronary syndrome patients. So is that right, or do we need an LDL level?
Yeah, so I think in general, I think that's good practice to make sure that all patients with ACS should be on a statin. That's essentially following the guidelines. So that's a good thing. So definitely keep doing it. As far as what dose to give, and the statin itself, even in the guidelines, they define it as high potency. So there are some statins which are not high potency, so don't prescribe them for patients who have acute coronary syndrome. As far as how much you want to bring the LDL down, usually 70 is the usual target. Now, obviously, you have to check to know, right? So that comes as part of the 6 months or annual visit of anybody who's had ACS before, is to make sure the LDL is controlled, just like you do with A1C. So A1C, you check you want the A1C to be less than 7. Also, you want the LDL to be controlled. because many times patients may change their diet, they may not follow instructions and things like that. And that's one of the things that can help reduce future events. And it's also established and well proven.
And just to add to Dr. Salah's answer is there was in the old times some concern about lowering the LDL too much, but with the newer medications coming out, all the research that has been published recently did not prove much of a harm with lower LDL level. We have some trials with the PCSK9 agents that lower the LDL, they went down as low as 40 or 30 and there was no adverse events. So as Dr. Salah said, it's very imperative that the patient be on statins, and we check to make sure we're controlling it rather than worrying about the LDL being too low.
Yeah, I think, yeah, I agree.
Okay. I think this concludes our questions, Dr. Salah.
Okay, very good.
Thank you very much, Dr. Salah, as always, for your time and your help. And, oh, Dr. Salah, I think there's one last question that just came in and it's sort of important. It's about how to differentiate between aortic dissection with an ST elevation MI.
Yeah, so that's a difficult diagnosis to make. That's a difficult diagnosis to make. I think we talked about acute aortic syndromes the last time. And we said that sometimes ascending aortic dissection may extend, usually involving the right coronary artery. So you might get an inferior ST elevation MI in the EKG in somebody who has an ascending aortic dissection. So the question is which is which, right? Now that is one of the, if you look at the contraindications of thrombolysis, one of them is aortic dissection, right? So these are, that they do happen, but fortunately they're very rare. So the way you can tell, clinically they both come with chest pain, so chest pain is going to be shared. Both of them are going to have inferior ST elevation MI on the EKG. So it's either the prolonged symptoms or something is going to trigger you to do one of two things, either an echo or a chest X-ray. The chest X-ray may show you the widening of the mediastinum, while the echo will show you the large pericardial effusion, which is usually associated with this. And you can also see the dissection and the aortic regurgitation that may or may not be there, but you'll also see the ascending aortic root. As I said, fortunately, this is rare, right? So this is, yeah, to have an ascending aortic dissection in general is less common, way less common than ST elevation MI. Ascending aortic dissection with involvement of the right coronary artery is also not that common. So these are generally uncommon, but they do happen. So the thing that you want to avoid doing, you want to avoid overthinking it, okay? So, and this happens with hesitancy. And that's something not to do with, if you're worried about getting a stroke and if you're worried about harming the patient, you'll start thinking about things which are rare. You may start digging deeper than you should, okay? You want to be careful, but you don't want to be over careful. You don't want to be over cautious. Because one of the things that I've noticed when I'm practicing in Sudan is that over caution deprives a large number of patients from getting timely thrombolysis because there is fear about complications, and that is valid reason to be cautious, but it's not a valid reason for patients who STEMI not to get timely reperfusion. I think part of that may also be that we need more cardiology backup in places where STEMIs happen. I think having STEMI networks helps. Training physicians in detection of the EKG, developing links between tertiary centers and people who care for patients who come to the emergency room will help a lot. So I think, education is a big part. This is a major problem. Education is a major part of it. Having the resources is part of it. But hopefully, I think information about how many STEMIs we see in Sudan, hopefully things can move in the direction of making sure that we give the best to our patients.
Okay. And the last question is about side effects of statin-like myopathy, especially when we give high doses. Is there any need for monitoring, for side effects?
Can you say the question again?
The question is monitoring for statin side effects like myopathy, especially with high-intensity statins.
Yeah, usually symptoms. So patient will tell you I have pain, and you should check a CK once a year. So these are the two things you do. So CK once a year, and patient symptoms. If the patient does not have symptoms, their CK is normal, then nothing to worry about. Avoid over testing. I think that's another thing important. برضو من الحاجات اللي لاحظتها في السودان إنه people get if the patient is doing well, then don't over test him. Don't over test. If the LDL is controlled, don't check it every 3 months. Check it every 6 months. Check it once a year. Avoid unnecessary testing. I've seen patients who get tested their CBC every 3 months. That's unnecessary. You know. Just do it if you need it. If you don't need it, don't do it.
اوكي فنيابه عن نفسي انا مازن عمر من خالد وعن جمعيه سابا بنشكر دكتور صلاح أبوسين على مساهماته الثرة ومحاضراته القيمه اللي بدينا لها، ونتمنى نشوفك ثاني ان شاء الله دكتور صلاح. بنشكركم الزملاء الاعزاء في السودان وبرا السودان على مشاركتكم في محاضراتنا وفي سلسله المحاضرات بتاعت مراجعه امراض الطب الباطن والانترنال ميديسين سيريز ريفيو. محاضراتنا عاده كل سبت، لكن عشان تكونوا على اطلاع على المواعيد وعلى المحاضرات السابقه موجوده في يوتيوب على قناتنا بتاعت سودانيز امريكان فيزيشن اسوسيشن. تابعونا على قناتنا في تليجرام سابا ام سيريز ريفيو، ونتمنى نشوفكم ثاني ان شاء الله. السلام عليكم. شكرا دكتور صلاح.
شكرا مازن. السلام عليكم.